Hello, this is Habib Srour, one of the attendings with anesthesiology and critical care here at the University of Kentucky. I'm going to be talking about the diagnosis of respiratory failure. Some of our goals and objectives for this podcast will be to develop an understanding of basic respiratory physiology, develop an understanding of the causes of respiratory dysfunction, and to identify the various options for treatment of respiratory derangements. Learners should be able to identify the normal components of respirations, signs and symptoms, and laboratory indications of respiratory dysfunction, and identify the causes of changes in Shunt and Deadspace. Talk a little bit about the alveolar gas equation and its relationship between room air oxygenation and ventilation, as well as some of the proposed treatment modalities for different types of respiratory failure, and some of the risks and benefits of those modalities. So, in normal respiration, you have two primary components. You have oxygenation and ventilation, and to some degree they can be mutually exclusive. So if you take ventilation, ventilation is done in order to clear carbon dioxide. The reason that oxygenation and ventilation can be separate really comes down to the solubility of the gas that's involved. So ventilation for carbon dioxide is soluble. It's quite soluble in blood, much more soluble than oxygen is. It's a perfusion-limited substance when it comes to blood flow through the lungs. There's a rate of accumulation associated with apnea with ventilation, and that is in the first minute 6 millimeters of mercury of CO2 partial pressure increases, and then after that it goes up by 3 millimeters of mercury every minute with apnea. So what does this mean for the ventilated patient? So if you think about having a patient that's on the ventilator and that is on controlled respiration, and then you turn off the ventilator, there's a time until you hit that respiratory trigger if the patient's apneic. Right? So if their trigger is set because of the various substances that you've given the patient, like narcotics, and because of the level of stimulation from the surgery, if they're not going to breathe until their end-tidal CO2 is 50, and you've been ventilating them at an end-tidal CO2 of 32, then it's going to take a full 5 minutes of apnea before they start to try to breathe. Okay. If you have respiratory failure that is due to a ventilation issue, then it's called a hypercarbic respiratory failure. It's important to remember that there's a differentiation there, especially from the standpoint of diagnosis. Oxygenation is obviously related to oxygen. It's not very soluble. It's diffusion limited in the lungs. There's a rate of use associated with oxygen. It's 3.5 cc's per kilo per minute in a normal person with a normal rate of metabolism. So there's two questions related to this that's pretty critical to understand. If you get not much else out of this, understanding the difference between these two situations is pretty important. So the time until a patient desaturates during these two circumstances: one, when you are inducing them and getting ready to intubate them, and they are thus apneic and there's no patent conduit for oxygen to get down into their lungs, and the time until desaturation when a patient is intubated and you are trying to wake them up and trying to extubate them, and they're on oxygen that's going through the ET tube. We'll talk about that in the next couple slides. If you have a respiratory failure due to hypoxia, due to an oxygenation issue, it's called a hypoxic respiratory failure. And then there's also the idea of a mixed respiratory failure that includes both. So if you have a patient and you pre-oxygenate them and denitrogenate them with 100% oxygen through a face mask, and you get them to an end-tidal O2 of 80%, which is what we typically do when we're going to induce someone for general anesthetic. In order to calculate how long it's going to be before they desaturate, making some assumptions, You take 80% of the volume of their FRC, their functional residual capacity, what's left basically when they are at a relaxed position after you've given them neuromuscular blockade. That is generally around 35 cc's per kilo in an average adult. So it's nice, it actually ends up being right around 10 times the amount of consumption per minute. So in ideal circumstances, you take 80% of this volume, call that how much oxygen is in there, and then they consume this much per minute, the 3.5 cc's per kilo per minute, and you end up landing right around 8 minutes. So in ideal circumstances, it will take about 8 minutes for someone to run out of oxygen in their lungs if they were to go to no oxygen in their lungs with apnea. So the idea here is as long as that's the case and there's no patent conduit for oxygen, there is a time limit here related to the volume and amount of oxygen that's in the FRC of the lung. Now the other situation we talked about, the time until desaturation, if you have a patient who's intubated and they're on 100% oxygen, and then you turn the respiratory rate of the vent down to 0, and the patient isn't moving any air, okay? As long as there is a patent conduit for oxygen getting from the source, which is the ventilator, down to the alveoli, then passive oxygenation is sufficient. This is the whole idea about how much oxygen is actually going in there and how soluble it actually is. It's not very soluble, right? So you end up oxygenating sufficiently, and the only thing that actually makes you desaturate is when you've accumulated so much CO2 in those alveoli, around 45 minutes down the road, that oxygen can no longer passively diffuse into the alveoli and continue oxygenating the patient. So this is of critical importance because CO2 will cause harm to such a patient well before hypoxemia occurs. And to some degree this is mimicked in the recovery room and in other areas where patients receive supplemental oxygen, and the novice will say that the patient has adequate respiration, but really all we know is that the patient has adequate oxygenation, short of doing a blood gas or some other invasive technique to find out what the patient's carbon dioxide is and how well they're ventilating. This principle is placed into practice during apnea tests that we do for brain death examination. So we try to optimize the situation, give the patient 100% oxygen through an ET tube with a patent conduit, and we leave them apneic for 10-20 minutes, and they never desaturate. But we're looking for CO2 to accumulate to a certain point to see if there's any respiratory effort with a ventilatory threshold. So some of the basics of breathing. Spontaneous ventilation is pretty basic. The diaphragm contracts, the lungs pull down. There's negative pressure in the alveoli, and air is drawn in. During exhalation, the diaphragm relaxes. You get passive relaxation of the chest wall muscles, and recoil to elastic neutrality, which is the FRC, the functional residual capacity that we just spoke about on the previous slide. With positive pressure ventilation, you have air that is pushed into the lungs. So the implication here is that the air goes where it's going to go depending on different factors as compared to spontaneous ventilation, because the diaphragm contracts and pulls at different points of the lung to different degrees. So in diseased lungs, for example, you get this issue of dynamic hyperinflation. If you look down at the chart here on the screen, essentially as the patient exhales, you get the patient's closing capacity and FRC changes and increases, and when the patient exhales, the small airways collapse before they're able to exhale the air that's in those parts of the lung, and so you get this essentially auto-peeping, where there's a slow increase in the FRC and ultimately an increase in airway pressure and all of the bad things that can result from that. As far as the respiratory failure is concerned, you have the signs, symptoms, and labs that are all important. So signs, you think of tachypnea, accessory muscle use. You can see here what some of the things that you'd look for on someone's physical exam with accessory muscle use and retractions. Symptoms, just subjective, shortness of air, smothering. And then with labs, you look at the bicarb, at the CO2, if you have a blood gas, um, and you look at the PF ratio for oxygenation. We'll talk more about that here. So to get to the meat of the matter, we talk about the respiratory physiology, and that is one of the critical tenets of it is the idea of VQ, ventilation and perfusion. And think to yourself what the extremes are of VQ mismatch. So we have V with no Q, so we're ventilating but there's no perfusion. That's called dead space. And you have Q with no V, so you have perfusion but you're not ventilating, and that's called shunt. And then this is obviously on a spectrum, so you have different alveoli that perform differently depending on where they are. So the take-home point here is the bottom line is that both dead space and shunt have an effect on end-tidal CO2. We're going to call end-tidal CO2 here because that is the non-invasive thing that we have that we can look at just looking at a patient. And the oxygen saturation, again, on the pulse ox. However, what happens first, what's impacted first by a change in each of these things, in dead space and shunt, is different if the patient has any reserve. Okay, you can think to yourself about what would happen with each situation if the patient has an increase in dead space. Then what will be expected to happen first is they should have a decrease in their end-tidal CO2. Okay, and this again comes back down to what we talked about before with the solubility of the different gases. If they have an increase in shunt, you should expect a decrease in their oxygen saturation. Okay, we'll talk about that here in a minute. What I would say is, there are a few things in medicine that are absolutes and that are really worthwhile to memorize because there are very few exceptions to them, and this is one of those things. If you're like me and you just need something quick that can help you remember the terminology, just remember that oxygen saturation, both O for oxygen and S for sat, are close to S for shunt. So it should become reflexive. If the patient has a problem with saturation, you should be thinking about causes of shunt. Whereas end-tidal CO2, the E in the end-tidal and the C in CO2 are both close to D for dead space, and once again, it should be reflexive. If a patient has a change in their end-tidal CO2 or in their arterial CO2, it's just in a different direction, then you should be thinking about causes of dead space. So the west zones of the lungs, this is what they look like. You have lungs that are in an upright patient, and you have zone 1, 2, and 3, and there's a relationship associated with these, and this is really the application of shunt and dead space. A simple way to think about this is that here you have the relationship between the airway pressure, the big A, the arterial pressure, which is the little a, and the venous pressure, which is the little v. The little a is always going to be greater than little v. This isn't a situation where the Nile is changing course and flowing in the opposite direction. The artery is always going to be flowing towards the vein. So what varies is the airway pressure. In zone 1, which is the highest here, in terms of relative to gravity in an upright patient, your big A, your airway pressure, is relatively the highest. Another way to think about it is that the blood pressure is relatively the lowest. You're highest in relation to the heart, so the pressure there is going to be lower. It's the same idea as when you sit a patient up and you have to move your transducer if you're interested in the blood pressure in the head versus at the neutral position. Okay, and in zone 1 the airway pressure is the highest. In zone 2 the arterial pressure is greater than the airway, which is greater than the venous, so it's right in the middle. And in zone 3, the arterial and venous pressure are both higher than the airway pressure. So think about what these would correspond to. If you had to label one of these shunt and one of these dead space, think about what that would be. Okay. So we kind of skipped over a second, but the zone 1 here is dead space. So dead space, you have ventilation without perfusion. That makes sense. Your airway pressure is high. It's higher than your perfusion pressure. So the alveoli, if you just want to think of it simplistically, the alveoli have a high airway pressure. There's air coming in, and the blood pressure cannot overcome that airway pressure and actually perfuse. So you have dead space. And zone 3 is the opposite situation. Your airway pressure is pretty low relative to your blood pressure, and so when air tries to get into those alveoli, it can't overcome the fluid pressure that's in there, and you end up with shunt, okay, which is perfusion without ventilation. And one of my mentors, Dr. Hatton, always called zone 2 zone awesome, because that's what we're trying to optimize, what we're trying to get when you have a patient with either one of the respiratory failures. So if you think about causes of changes in dead space, and what you should be doing now is in your head thinking, what does that mean? Dead space is what? Dead space is CO2. Okay? So when you think about causes of dead space, think back to this chart here. What are the situations that would increase our airway pressure relatively, or that would decrease our arterial pressure and our blood pressure relatively? And that kind of makes things more apparent. So if you have a PE, that's a special case, we'll talk about that in a minute. But if you have a PE and you occlude part of the vasculature, you're going to have an area that is ventilated without perfusion. The perfusion is cut off. Dead space is dead. It's not getting perfused. Okay. In positive pressure ventilation, you're obviously applying positive pressure. So the big A, the airway pressure, is going to be high. Anytime you do that, you're increasing your dead space. One of the things that I neglected to mention in the previous slide is that anything that you do generally to optimize one of these things, dead space or shunt, it generally hurts the other one. And that kind of makes sense when you look at this relationship. So positive pressure ventilation, it increases your dead space, but it improves your shunt fraction. Okay, so you're going to move a lot more of this big A down here in zone 3 to the middle, and so you can improve oxygenation that way with positive pressure ventilation. That's once again, shunt. It should click in your head that shunt is related to SAT. Airway devices are important. When you put a tracheostomy in someone, that it decreases the dead space significantly compared to when you put a big face mask over someone, which adds a whole lot of dead space between the patient and the outside world. And then shock. Shock is a critical one. As anesthesiologists, one of the things that we look at on a patient where we're having trouble telling if they are indeed hypotensive or if they've gotten suddenly hypotensive, we're waiting for the cuff to run, and you automatically look at the end-tidal CO2. If the end-tidal CO2 drops or disappears, hopefully not, then you have a huge cause of dead space, meaning you're not perfusing, right? If you think back to ACLS, if you've done ACLS, one of the things that you titrate compressions to is end-tidal CO2. You should be doing compressions well enough that your end-tidal CO2 is greater than 20. And the idea there is that you've minimized dead space enough because you're perfusing well enough. Causes of changes in shunt. So we said PE was a special case. The idea there is that 20 to 40%, it depends on what you read, of PEs are large enough that they cause changes in the blood pressure as well. They increase your right ventricular afterload, and you increase this arterial pressure as a result, and you end up also getting shunt. So you get both things. So if you have someone that has a PE that is hypoxemic, you need to be worried. And these are the people that we see in the ED, right? These are the people that come in short of breath, you put them on a pulse ox, and it's not very good. That means that this is a big enough PE that it's also causing shunt. It's having some impact on the hemodynamics of the right ventricle. In the operating room, when you see an orthopedist hammering on the femur, and you watch and you see the end-tidal drops in a stepwise fashion, those are smaller PEs. You know, they're getting changes in their dead space, but their shunt fraction probably isn't changing all that much. So it's important to realize that what we see on a day-to-day basis in the emergency room or in different scenarios impacts what our view is of something that we see clinically. We talked about positive pressure ventilation having a benefit here. Obstruction is a big cause of shunt, right? You're looking at perfusion without ventilation. So asthma, mucus plugging. These are things that when you see a change in your oxygen saturation, you should be thinking of these things, of causes in shunt. Intrinsic lung disease, pneumonia, pulmonary edema, CHF, Pulmonary contusions, trauma is a big situation here. You get pneumo and hemothoraces. Those are situations where you have an increase in shunt. Atelectasis is a big one after abdominal surgery and other situations. Main stem intubation is a critical one. We talk about prone ventilation. You do prone ventilation in order to decrease your shunt fraction. So it's in parentheses because it improves shunt. If you look at what the lungs look like in a patient that is supine, the largest segments of the lung are posteriorly. So if you're laying on your back, what is the largest section of the lung? If you look at this chart, it's going to be shunt. So if you have a patient that has difficulty with hypoxemia, you prone them, and it's been shown repeatedly to be very beneficial. We won't talk about intracardiac or intrapulmonary shunts, but these are things like hepatopulmonary syndrome and actual malformations within the heart. So some case scenarios here. So non-invasive positive pressure ventilation. A couple things to think about. So when you have this concept called the VD to VT ratio, the dead space to tidal volume ratio. In spontaneous ventilation, roughly about a third of every breath you take is dead space. When you change it to positive pressure ventilation, of course this depends on how much positive pressure you're giving, but you end up with about a half when it comes to this ratio. So why does that matter? We'll talk about that in a second. You have a couple modes of positive pressure ventilation. There are more than a couple, but the big ones are CPAP and BiPAP. And you should think about why you would choose one over the other. Why would you put someone on CPAP? What is the situation where that is the best choice versus BiPAP? So the way to think about it is going back to our west zones of the lungs and shunt and dead space. So if you have a patient that has a problem with a hypoxemic respiratory failure, you're going to put them on CPAP because you're increasing your mean airway pressure, that big A, you're decreasing your zone 3, you're decreasing your shunt, and you're improving their oxygenation. If you do that, what do you do to their dead space? So remember, if we're increasing that big A, we're creating more dead space. So if a patient has a mixed respiratory failure, meaning they're hypercarbic, they have a lot of dead space, and they're hypoxemic, they have a lot of shunt, and you put them on CPAP, you're going to precipitate a hypercarbic respiratory failure. Okay, you're increasing their dead space, and their effective ventilation is going to be less. So in a mixed respiratory failure or in a hypercarbic respiratory failure, you put them on BiPAP. Now, BiPAP is also guilty of increasing your dead space. Arguably more so because you're increasing your mean airway pressure more than you would with CPAP. The difference is the reason that BiPAP works is it helps a patient move more effective tidal volume. This is one of the reasons why BiPAP, you have to really know and understand this physiology to understand what makes BiPAP work and what makes it fail. So looking at a case here below, you have a patient, just for simplicity's sake, they're breathing 300 cc tidal volumes 10 times a minute and spontaneously. And in this circumstance, their CO2 is rising. You're checking gases and it's getting worse. Okay. Now you put this patient on BiPAP and they're taking a 400 cc tidal volume 10 times a minute. Did we help this patient? Okay, and I wouldn't be asking this if the answer was yes. The answer is no, we did not. If you look back here with the VD to VT ratio, if you increase the positive pressure in the patient's lungs, their effective ventilation, so their effective tidal volume here spontaneously is 2/3 of 300 or 200. With the BiPAP, their effective tidal volume is half of 400 or 200. So we have not effectively increased this patient's ventilation. And this concept is one of the reasons why BiPAP has repeatedly been shown to fail as a rescue therapy. Meaning if you try to put a patient on BiPAP when they are no longer able to contribute to their minute ventilation, and all of the work has to be done with positive pressure, it's going to fail because you have to give so much positive pressure to make this tidal volume that the dead space is increasing proportionately and the patient is not moving effectively any more air. Okay? And all of this applies to ventilator modes as well, invasive ventilation, using PEEP and CPAP and other things. So another case scenario, you have this, you have the alveolar gas equation, which every anesthesiology resident has to learn for boards. Why is this important? So if you look at a patient, there is no non-invasive way to tell if a patient is adequately ventilating under any circumstances except for one. And I encourage you to think about this, and if you can think of a different scenario, feel free to let me know, and I'd love to talk about it. But when you look at a patient that's in a PACU slot and you have a pulse oximeter on them, and you have capnography, let's say you have capnography on them, and you're looking at them, and they're moving what looks like good air, you cannot tell if that patient is adequately ventilating, short of getting a blood gas. Okay, you have to do something invasive. They might have a huge dead space ratio. So even though they're moving a whole lot of air and their end-tidal CO2 says 30, that doesn't mean anything to their blood if their dead space is enormous. Okay. So what is the situation that is exclusive here? So first, there's a mantra that we all learn here from Dr. Bo, and I thank him for most of the framework that I developed in order to write this lecture. He has a mantra. He says 30 is 60, 60 is 90, and 40 is 75. So this is the PaO2 to saturation relationship in normal adult hemoglobin. So at a PaO2 of 30, you expect a saturation of 60. PaO2 of 60, you expect a saturation of 90, and so on. If you take the alveolar gas equation, which is listed here, the P big AO2, so the alveolar oxygen, is the FiO2 related to the atmospheric pressure and the partial pressure of water, so the humidity, then the CO2 and the respiratory quotient. So if a patient, what do you want to take out of this? So if you have a patient that is on room air, so there is no supplemental oxygen, the FiO2 is 21%, and they have a normal metabolism, so this respiratory quotient is relatively normal, so they're not hyperthyroid, they don't have malignant hyperthermia, neuroleptic malignant syndrome, etc., and their lungs are relatively normal. Okay, so this is not a patient that's on ECMO, obviously. Okay, and they have a saturation of greater than 90%. That necessitates, by this equation's very nature, that their PaCO2 is less than 70, and in a lot of cases less than 60. Okay, so this is the one circumstance. If you take a patient and you put them on room air, and their saturation stays above 90, you can feel fairly comfortable that they are adequately ventilating. Okay, when does this become important? Well, if you have a patient in the PACU, particularly a pediatric patient, or a demented patient, someone that cannot communicate with you about what is going on, and you get called by the PACU nurse, and he or she says, hey, this patient is tachycardic, hypertensive, agitated, I think the patient's in pain, I would like to give some narcotic. Well, you have to decide now, is the situation, because that presentation is the same for a patient that is in pain and can't communicate, or a patient that is hypercarbic and is becoming obtunded. So if you give that patient narcotic and the situation is the latter, then you've just done the patient a pretty big disservice. So what you can do in some circumstances is see what they do on room air. And obviously I would not leave the patient's side while doing this because it's not without some element of risk. But if you put the patient on room air and you stand there and the patient's saturation is 96, 97% on room air, then you can be pretty comfortable and say, hey, let's give a little bit of narcotic and give it at whatever interval and wait, if at any point the saturation on room air drops to close to 90, stop giving narcotic. And we need to reassess. But that's one way, one clinical tool that might be useful that's a practical aspect of all of this. So some treatments of respiratory failure. So you have supplemental oxygen, so nasal cannula, masks, tents, high-flow nasal cannula. You have non-invasive positive pressure ventilation like CPAP, BiPAP, and then the more recent one called AVAPS, and that's essentially a PRVC for a non-invasive machine. So you give it a range, and it tries to match some tidal volume by altering the pressure with each breath. You have invasive positive pressure ventilation, so with an ET tube or a trach. You have advanced invasive positive pressure ventilation modes, and you have ECMO. Some adjunct therapies for oxygenation. So diuresis, we talked about the causes of shunt, pulmonary edema is one of them, heart failure, and treatment of the underlying cause. Recruitment maneuvers, right? So decreasing your shunt fraction by opening up those alveoli so that they also get ventilated. Bag and suction when it comes to tracheostomy. So think about what happens to a patient when you trach them. You take away, all of their flow is no longer going through their cords. What happens to the cords when you exhale? They AD duct. And so you have what's called an intrinsic PEEP that goes away now. You've put in a tracheostomy. Tracheostomy helps when it comes to ventilation. It decreases dead space. But generally, you end up with more shunt because you're going to get atelectasis. You don't have this intrinsic PEEP. So bag and suction every once in a while with tracheostomies is helpful. Using a passe-mur valve, something that directs flow out through the mouth during exhalation, that also reduces the shunt fraction there. Adding PEEP, increasing FiO2, helps obviously with oxygenation. Proning we talked about. Inhaled vasodilators, so Flolan and nitric. These things selectively vasodilate the ventilated alveoli, so you improve your VQ matching there and decrease your shunt fraction. It draws blood effectively towards the ventilated alveoli. Paralytics, they've been shown to make a big difference in things like ARDS, where you're trying to avoid further damage to the lungs and allowing us to take full control with the ventilator, decreasing the patient's oxygen consumption so that we don't have to give them quite as much oxygen while they get through their acute illness. And then ECMO, which, the sky's the limit with ECMO. We won't talk any further about that in this venue. The flow curve is kind of a critical thing. When you use the PRVC mode on the ventilator, one of the benefits to using a pressure mode, which is what PRVC effectively is that the flow curve on the ventilator is a dependent variable. What you see here is dependent on the patient's lungs and lung mechanics, versus a volume control mode where this is controlled by the ventilator. The flow is controlled by the ventilator. So how can you use this? Well, if you have a patient with a curve like this, where the inspiratory flow, which is what's here above the x-axis here, the inspiratory flow doesn't hit zero at the end of inspiration. Right? There is still room, there's still flow going on during towards the end of inhalation. That means that there are slow opening alveoli. There are alveoli that are not getting air and are not being ventilated, and are likely still being perfused. So that's a shunt fraction issue. If you take 500 cc's of air and you put them into 500 cc's of lung volume, that's a lot more shunt fraction than if you take that 500 cc's of air and distribute it over 2 liters of lung volume, right? Just a lot of alveoli that are smaller versus a few alveoli that are larger. And you can do that by increasing your I time here so that this inspiratory flow gets close to zero, or hits zero. The limiting factor is that you also want to make sure that you don't auto-PEEP, that your expiratory flow hits zero before your next inspiration. So it's a balancing act there. The same thing happens here, which we're talking about here with the gas trapping, the auto-PEEP. This patient is exhaling and is not fully exhaling before the next inspiratory breath, where all these arrows are pointing. And you can see the I time here has the same issue. So this is just another representation of what we were talking about. So some of the general risks of the interventions that we do. So we talked about the dead space and shunt issue. What you do to improve one generally mucks with the other, and you have to kind of decide and find this balancing act. And the less reserve that a patient has, the more difficult this is going to be. The only mode short of ECMO, which bypasses all of this, the only thing that we can do to a patient that positively impacts both dead space and shunt that I know of is high-flow nasal cannula. So you put someone on 40 liters of high-flow nasal cannula, you're providing some CPAP, which improves your shunt fraction, and because of the flow that's flowing through your oropharynx and your nasopharynx, you actually clear out the expired CO2 from there, and you effectively decrease their dead space. So high-flow nasal cannula is a fantastic tool and can be useful in a lot of situations. Supplemental oxygen, anytime you do that, you're going to worsen your dead space, right? You're effectively blunting your hypoxic pulmonary vasoconstriction. The old wives' tale that when you put someone on oxygen that's a COPDer and you take away their hypoxic drive, that's not so much the case, right? All the studies show that they have the same minute ventilation when you put them on oxygen. The problem is that you've blunted hypoxic pulmonary vasoconstriction and you end up with less effective ventilations. When they take a 400 cc tidal volume breath, their effective tidal volume is less when you're giving them oxygen. They have much more dead space. And so they end up in a hypercarbic failure. And that's why in COPDers in the MICU, they'll target oxygen saturation of 88 to 92, so that they don't give more oxygen than is necessary, and so that the patient can clear CO2 more effectively. With non-invasive positive pressure ventilation, you have to think about aspiration. You have to think about tissue necrosis with these masks on the nose. And with invasive positive pressure ventilation, you have to think about HCAP, or pneumonias that are related to taking this plastic tube and shoving it through a dirty place into a clean place. Okay, and then there's also obviously the risk of placement with an ET tube. More of these risks. So with diuresis and treatment of the underlying cause, you have to worry about renal dysfunction. Most people would tell you have to decide whether you're going to flog the kidneys or flog the lungs, and decide which direction you're going to go. Recruitment maneuvers, you have to worry about hypotension, causing a pneumothorax. Right, anytime you put a lot of positive pressure in the chest, there's a good amount of risk associated with it, and I'd encourage you to watch your arterial line the next time you give someone a true recruitment breath. Bag and suction with the tracheostomies, you can cause bronchospasm. You can increase the risk of infection if it's not done cleanly. Increasing PEEP, well, that has an effect on right-sided preload, and it also has an effect on right-sided afterload. You're increasing your mean airway pressure, the intrathoracic pressure, which decreases the return from the venous side. If you add PEEP, as an aside, if you add PEEP to someone and you're continuously increasing PEEP and their oxygenation is worsening, you need to think about an intracardiac shunt, right? Because if you increase your right-sided afterload, that's going to make it more likely, if there's an intracardiac shunt, that it will be a right-to-left shunt. Okay, think about that for a minute. Make sure you understand what that means. Proning, the big deal is unattended extubation, and especially with the modern patient that in many cases is obese and morbidly obese in many cases, makes it very difficult to do proning. Inhaled vasodilators like Flolan and nitric, they're expensive. There's toxicity associated with them, methemoglobinemia. Anesthesiology residents will hopefully be aware that if you put someone on nitric in the operating room, you have to increase your fresh gas flow so that you are no longer in a semi-closed or a closed circuit, but in a semi-open circuit, meaning that your fresh gas flow has to be higher than your minute ventilation, and that the patient does not rebreathe their expired gases, any of their expired gases. Another thing with inhaled vasodilators that's not listed here is that they're also platelet inhibitors, particularly Flolan. So if you have a patient that's actively bleeding in the chest, there's implications there. Paralytics, there's the idea that potentially they contribute to weakness, especially after ICU. That's questionable, but it's something that's been suggested. And then the risk of awareness, right? If you give someone a paralytic and aren't being very diligent about their amnestics or what other sedative medications that they're on, that could be a concern. ECMO, you have the issue of access, thrombosis, hemorrhage. We've all seen the ECMO patient that has had an issue with pulses in their lower extremity because of their cannulation. So this is a nice little video that I always like to watch. So you have a situation here with alveoli without PEEP. And if you pay attention, you can see the alveoli collapsing and then opening back up. This is what contributes to the idea of adduct trauma and the shearing forces that happen on these alveoli. And here you have a situation where they're doing a recruitment maneuver. You can see that. And then they add PEEP. And if you just kind of pay attention to the different alveoli, you can see them moving in and out, getting bigger, getting smaller, but very rarely do they collapse completely, and so that mitigates the whole idea of shearing forces and adduct trauma. And in fact, here you can actually see an alveolus, a very slow opening alveolus that's opening just from the PEEP there on the left side. It's pretty interesting to watch that happen in real time. Okay. The idea of dynamic versus static compliance. So this is the argument for putting a patient on a volume mode of ventilation with a plateau inspiratory hold. It gives you an idea of the difference between the static compliance and the dynamic compliance. So what does this mean? So if you have a situation where the patient's peak airway pressures are elevated, but their plateau pressures are also are not also elevated. So there's a difference between your peak and plateau pressure. That tells you that the problem that's causing the elevated pressure is during flow. It's a problem with dynamic compliance. So it's a gas flow rate through the airways, and it's usually an airway resistance problem. So a mucus plug, a kinked ET tube, patients biting the tube, a foreign body aspiration, herniation of the ET tube cuff, bronchospasm, or COPD. Conversely to that, if you have an elevated plateau pressure, so the peak and the plateau are both elevated, then you have a problem with static compliance. It's a problem even when flow has halted. So usually it can happen from an increased tidal volume, but it's from a problem with general pulmonary or chest wall compliance. Pulmonary edema, pleural effusions, attention pneumothorax, ARDS, or ascites, anything in the abdomen can also contribute to this. Sometimes even just the surgeon leaning on the chest, especially in a pediatric patient or a small patient. So that was a fast run through of all of these things. I've gone a little bit over time, but hopefully it was something that was useful to you. As I've always said, I try to give you something that's useful and functional for when you walk into a patient's room and have to decide on what to do next and what's causing the problem that you're seeing in front of your eyes. If you have any questions or if you want to discuss any of these things, please let me know, and I look forward to seeing you guys in the intensive care unit where we can put some of this stuff into practice. Thank you much.